Hello, everyone. It's so nice to see you all today. Happy Thursday. Today I get to celebrate the one and only Shreyas, and I say that because um, well, I'll tell you the real story. We when the academy was beginning to coalesce and become a little bit more defined in terms of like how we were going to recruit people to the academy and what kind of people we wanted to be part of the inside workings of CP solvers. But there was one problem. Those rules weren't gelling well with Shreyas. He was here all day, every day, making such a profound impact. He was so positive, so kind, so smart, so gentle. But we were very stubborn about this idea that we wanted people to have presented multiple cases before we recruit them. And Shreyas, being where he is now, not actively clinically seeing patients, found it difficult to make up a case that he hadn't seen. And so we broke the rules. We broke the rules. We very rarely do, but broke the rules for Shreyas because we really felt that he was that special. And I think that our pre-test probability was validated by our post-test probability. Now people know that the rules can be broken. Uh-oh, that's a slippery slope. But more importantly, since he's been part of the team, I think that he, I don't know. I feel like the best way to tell you is whenever I see Shreyas thinking about medicine or discussing medicine, I see a little bit of me a long time ago. It both makes me feel really old, but also really inspired. I don't think you'll find many people out there who are as invested in really understanding medicine, and you can see that in his contributions here and in the tweets that he writes and in the reflections that he has with us in the Academy group. So, Shreyas, I'm really hopeful this is the beginning of a long journey for you where you get to dive into clinical reasoning. And I'm really excited to discuss a case with you. I'll pass the mic to you to say hi, um, and then we'll jump into phase two of this in a moment.
Sure. Hi everyone. So happy to be here, and I'm so thankful to know that you broke the rules just to let me be a part of this academy. And yeah, I actually wanted to present a lot more cases, and I think sooner I will be presenting a lot more cases. So I'm
Yes.
looking for some interesting ones, which we can have a fun time discussing together. And I just want to tell everyone who's watching there's so much of learning which we have through just by talking with one another and just through conversations. And I feel the amount of learning which one can transact in medicine just by having conversations and multiple minds picking at a particular aliquot of information is actually so enormous. And the amount of medicine I've learned just by being in regular with CP solvers over the past maybe 6 or 7 months is just enormous.
That's awesome. I think that that's just the beginning, which is the scary part. You know how much more you have left to learn, or all of us have left to learn. Um, we had a pre-scheduled case presenter today, but I don't think they were able to make it. At least I can't. Uh,
Hi, it's
ah,
actually me.
oh, hello. Oh my gosh, I didn't recognize your name.
Yeah,
I'm sorry, you're
it's
Zoom.
yeah, my name in official capacity is Abul Faz, but everyone calls me Khashayar. So yeah,
Oh,
there's a
hi.
difference in name. Yeah,
Wow.
sorry
What a
about that.
No, please don't apologize. That's so cool. Tell us a little bit about yourself. Tell us a little bit about yourself, please.
Well, I'm a fifth year medical student in Iran. I don't know how that translates
Yeah, yeah.
well internationally, but it's my first year in the hospital.
Yeah.
I'm a first year extern, and the case I'm presenting today is actually the first case I saw in the
Oh,
hospital.
that's incredible. That is so cool. So tell us the story behind your name.
Well, it's a long story actually,
We
but
have
we
time.
had a car crash when I was 3 years old,
Oh,
and I was thrown out of the back window, and I was lost because apparently someone found me and took me to a hospital.
oh my God.
And well, my mom is kind of religious, so
Uh,
I don't know how to translate what she kind of did, but the story goes that she prayed and my name changed to Abul Faz because she found me. after the accident.
Wow. Oh my gosh, that's incredible. Uh, I don't know what to say to that. Um, I do you well, one, how old were you? Do you remember any of
I
this?
was 3 years old. I
Yeah,
don't
so you probably don't
remember it.
remember any of it, huh?
No.
Wow. Well, I'm really glad that you tumbled safely out of the car and slowly but surely made your way here, which is really cool that our worlds are colliding in that sense. Wow, that's I think by far and away the most fascinating name story I've ever heard. And so you said that your nickname is different than your official name. What's the story
Yes.
behind your nickname?
Well, Khashayar is my actual name, like the name
Oh,
before it got changed.
I
That
see.
one stuck. Everyone knows me as Khashayar, but in an official capacity, I'm Abu
I
Faz.
see. Oh my gosh, even cooler. Wow. Okay. Well, welcome. It's such a thrill to have you here. I'm curious if you wouldn't mind taking a moment to tell us a little bit about you outside of medicine. I see a lot of books behind you. What does your life outside of the medical world look like?
Well, I'm an open source enthusiast.
Uh,
I am an avid manga reader, and I write short stories for my girlfriend when I get the inspiration.
really? Oh my gosh. I feel like if I didn't know you were Persian, I know it now. Long, long history of poetry is almost genetic. That's really, really cool. Uh, so you're in your fifth year now. Do you have a sense of what you want to do in medicine?
Uh, I will probably go to internal medicine. I don't know if I go deeper into subspecialties. I like being a generalist, but for now, yeah, I'm
Amazing.
pursuing internal medicine.
Wonderful. Well, it's a thrill and honor to have you here. I will make you co-host in case you have any pictures to share. Um, and we're very, very excited for your case. Thank you for putting it together. Ironically enough, not ironically enough, a fellow Iranian person, Parisa, is scribing today. So as you nod and probably realize that yourself. All right, Parisa, take it away, please.
All right, should I start?
Yes, please go for it.
So, our patient today is a 24-year-old male who was referred to our sentence due to diarrhea, significant weight loss, and refractory hypocalcemia. And the patient's symptoms started at the age of 8 with fatigue, jaundice, and anemia, and watery diarrhea. And those symptoms have persisted till today with changing severity, but they have been with the patient till now. Uh, the diarrhea has worsened since 2 months ago. The weight loss has been 20 kilograms in the past year. The patient also has hypomagnesemia and hypokalemia, and they were referred to our center for further evaluation and treatment. And I think we can stop there for the first alcohol.
Amazing. I should ask you, what do you prefer us to call you since we have two options for the rest of the hour?
Hashayar, but
Okay.
generally I'm fine with both.
Okay. All right, Khashiyar, we'll stick to that for today. I think Shreyas, I'll just start um, by trying to just acknowledge how much information it is to process when somebody this complicated is transferred to your center. So much so that our very talented scribe will never be able to keep up. It's a lot. So let me take a moment to sort of summarize for Khashiyar to make sure that we got all the data correctly. So we know this is a 24-year-old male who was referred principally for diarrhea and weight loss. And the context for that is the additional features he seems to have is refractory hypercalcemia.
Hypocalcemia.
Hypocalcemia. Okay, thank you. Hypocalcemia. And then just to continue the theme, he also has low mag and low potassium. And then two other features in addition to this were anemia and jaundice. Is that right?
Correct?
Awesome.
Completely.
So if you make a list of things that you have now, you have diarrhea, weight loss, anemia, hypocalcemia, hypomagnesemia, and hypokalemia. 6 things, right?
Right.
And the interesting dimension of them to understand them over time is it seems that many of these things have been long-standing. Some things started when he was 8 years old, and maybe, Khashar, I'll ask you to clarify. If you wouldn't mind just kind of summarizing, beginning at 8, what symptoms he had and how it evolved, just one more time so we understand the
Uh,
nature.
okay, I'll tell some of it because I saved most
Oh,
of
I
this
see. Okay.
involvement for the past medical, but the symptoms that started at 8 years old were fatigue,
Hmm,
anemia, watery diarrhea, and jaundice.
I see. Understood. Okay, terrific. Um, So Shreyas, I think part of the hard part is knowing where to begin. Of all those 6 things, where is your mind focusing in on and beginning?
Sure. I think this is a very complex set of problems to start with. I think, like you mentioned, 6 different problems to tackle it at once is a challenge, but I'm going to try here. So, this is a 24-year-old person, and then he's been having diarrhea for almost all of his life now, so for close to 16 years. And so that puts us in the category of thinking about what's causing the chronic diarrhea. And when I'm thinking of something like a chronic diarrhea, I'm thinking about could this be inflammatory in the form of inflammatory bowel disease or Crohn's disease, or could there be some sort of a chronic infection? Or I'm also worried about if the person has been immunosuppressed for all this while, because HIV can produce a similar side kind of a presentation. And also, with the various opportunistic infections which can come with HIV can produce a chronic diarrhea. And but then the fact that he's also been having the worsening anemia and jaundice. I'm also thinking about when I'm thinking about the worsening anemia, I'm also thinking about is there something which is causing a malabsorption kind of a picture because he's having a wide range of electrolyte abnormalities. And when I'm thinking about a malabsorption, you can think about anything all the way from the mouth all the way to the rectum, which can be causing malabsorption, and anything with the hepatobiliary tract, which can also be causing malabsorption. And such a young age, I'm also thinking about the possibility of something like an autoimmune kind of a presentation. And when I'm thinking about anemia, weight loss, and a failure to thrive kind of a picture, I'm also really strongly considering at this point of time celiac disease. Although it is too early right now to think of a final diagnosis, I'm just keeping that at the back of my mind for now. And like I was mentioning, thinking about the digestive tract all the way from the mouth to the rectum, anything which can cause anything which is be deranged along the process can result in a malabsorption kind of a picture. So I'm thinking about things which affect the intestine, like I mentioned earlier, inflammatory bowel disease. And the duodenum, like I mentioned, was a classic site where celiac disease can be affected, and Crohn's disease, ulcerative colitis, all across the colon, basically. So those are some of my initial thoughts. And I really was also thinking about travel history and any sort of infection that this patient acquired, but it's been going on for like 16 years right now. So I think that is far less likely at this stage. And thinking about the electrolyte abnormalities, I think we can, I think I would love to discuss that once we reach the chemistry so that we can have a better discussion there.
Oh my gosh, Shreyas, I hope you took a breath in the middle of all those thoughts. You can breathe now. I think what's interesting to watch in your response is how many thoughts you had, right? And the discussing stage makes all of us want to talk about most of them and share them with ferocious velocity, right? That's what happens. And there's no way in real life you would be thinking the way you just did right now, because it's impossible to have that many thoughts. So now that you're in the context of this exercise, I would love to take you into a different context where this person is standing right in front of you. And I would love for you to take those thoughts and ask yourself, what are you going to try to accomplish in the next few minutes with this patient? Like, what would be the action steps to get more clarity? What would you want to know?
Sure, Dr. Ravi. I'm going to use one of the suggestions which you had actually shared with me the very first time we spoke, and that is ask a lot more questions. I feel just by asking a lot more questions, we can uncover a lot of different things. So if I see this patient in front of me, one of the first things I'd be doing is ask for additional symptoms. I'd ask if the patient, for example, has been having worsening fever, and also the fact that he's lost 20 kgs over the last year. I think there's something which has drastically gone wrong since the patient's baseline, because he's been having diarrhea all his life. But the real alarming feature right here is the weight loss. So I'm bothered about some malignancy also. So maybe ask about constitutional symptoms, like maybe is the patient having night sweats? Is the patient having fevers which are coming on and off? So I think asking some of those questions will help me move with the diagnosis in this at this stage.
Yeah, I agree. I think you need a lot more clarity on everything, and it's hard to know what is cause or consequence. For example, in anybody with diarrhea, it's very plausible for them to be hypokalemic and hypomagnesiemic. So my mind is not interested right now in those specific electrolyte abnormalities, and I'm lumping them under diarrhea. Hypocalcemia can be the result of hypomagnesemia. And so it might turn out to not be, but I think it's very easy to say that low mag is from the diarrhea, and the low mag is causing low potassium, and the low mag is causing low calcium. And so I don't really invest too much in those right now. And so I'm lumping this to just diarrhea alone. What's more interesting is a problem representation that has the following words: chronic jaundice. Chronic jaundice is an incredibly unusual thing because jaundice is often the harbinger of tremendous morbidity and mortality. And if more compromise has not ensued in a short period of time, it really is a profound filter. So for me, this is a chronic diarrhea featuring jaundice and anemia. And I think whenever you hear jaundice and anemia, you have to be careful. It's very tempting to wonder if the patient has a hemolytic anemia causing indirect hyperbilirubinemia. But any form of liver disease can contribute to anemia through a variety of mechanisms, most classically a macrocytic anemia associated with chronic liver disease. So I think the next phase of the evaluation is to simplify the problem and to assume the electrolyte abnormalities are actually not 3 additional problems, but a consequence of one of them, to allow this problem to be simpler to solve. And so I think the most important next step is to understand, is this jaundice a heme issue or is it a hepatic issue? And the progress you can make on that in one moment is infinitely more than the progress you can make on watery diarrhea. The goal will be to try to classify that watery diarrhea into an inflammatory diarrhea or a non-inflammatory osmotic or a non-inflammatory secretory diarrhea. In patients who are having weight loss with their diarrhea, the least likely consideration is secretory diarrhea, as the pathophysiology just implies loss of water, i.e. secretory, without loss of nutrition. And so secretory diarrhea can involve weight loss through some less common mechanisms, but its presence really suggests either inflammatory or malabsorptive states. So right now, I'm not thinking about anything, or actually, to be honest with you, Shreyas, I'm not thinking about asking the patient questions now. I'm really invested in looking at the prior bilirubin. Because if I see that it's mostly direct or indirect, my whole questions for the patient will change based on that finding. And I know that data is there. So my first step is look at the prior records, what's the bilirubin, and then based on that hypothesis, ask very targeted questions to help make progress. We were off to a great start, my friend. What did you have next for us?
So I want to clear something up at first, that while the symptoms were persistent, the jaundice was kind of like on and off. It stopped and then it was episodic. So first I'm gonna give you all a title of past medical histories, and then I'm gonna go over how the symptoms developed over the years. There was a diagnosis of celiac disease at around 10 years old for the patient, but the diagnosis is not documented. It's what the patient told us, and he does not remember a change in diet or anything like that. An allergy to a food that their physician has told them, nothing like that. They just told us that they had celiac disease. Other prominent past medical history would be a diagnosis of mucocutaneous candidiasis, GI candidiasis, a delayed puberty at age 18, a diagnosis of diabetes mellitus type 1, a diagnosis of adrenal insufficiency, hypoparathyroidism, and hypothyroidism. So this is the overall past medical history. The development of symptoms over the years, I hope my system can share my screen with you.
Yeah, you should be able to,
Gonna-
my friend. Let me just make sure. Yeah, you should be able to. Oh,
no, there may be a problem with my system.
oh,
I'm
I
gonna
see.
try. Can you see can you see my screen? Or
It
is it
looks
just
like
blank?
it looks like it's saying it started screen sharing. Let's give it a second because sometimes it turns into a screen, but unfortunately, no, I don't think so. You know what
Yeah,
you
there is.
can do if you like? I emailed you I just saw you responded. If you want, you can email it to me and I can share it if you like. But otherwise, we can
Sure.
um happy to do without it. But maybe in the meantime, since the medical history is so rich, I'm curious, Shreyas, what did you register with that medical history?
Um, the fact that this patient has been having all of these endocrine disorders, multiple endocrine disorders, he's had issues with the parathyroid gland, he's had very young onset diabetes. So I'm definitely also considering the fact that maybe multiple endocrine organs are involved, like polyglandular autoimmune disorders. And also, when I think about multiple organs being involved at the same time, I'm also thinking about certain infiltrative conditions which can affect multiple organs at once and produce such a kind of produce multiple dysfunctions at one time. So those are some of my thoughts, but at this point I'm still not able to understand how to tie that in with the chronic diarrhea which this patient has been having, and also not sure why it's been worsening for since, and why he's been having this weight loss since the past 1 year. So that's one thing which I'm still not able to explain well.
Yeah, I think I'm there with you. I think whenever you see so many autoimmune endocrine issues, it's hard not to worry that they might be related in some way, shape, or form. And we'll talk about that in a moment in more detail. But I would love, before I start to reflect, get also your thoughts on what happened in your mind when you heard that the jaundice is episodic. What happened to that dimension of this case for you?
Um, Honestly, I really don't know how to explain that the jaundice has been on and off. I was thinking maybe if the jaundice could be on and off, maybe for example, if there's a hemolysis during periods of stress, maybe that could cause a elevation in bilirubin and cause a jaundice only during those periods of stress. For example, sickle cell disease, although we
Right.
don't have that in the past medical history, maybe just episodic hemolysis every now and then. That would explain a rise in the indirect bilirubin. But then if I were to say what could be the on and off jaundice and explain that in the context of an obstructive jaundice, the only thing I can think of is maybe CBD stone, which has the ball valve phenomena, which is coming on and off. That's the only way I can explain the on
Yeah.
and off jaundice. Apart from that, I really don't see
Yeah.
another explanation.
Yeah, what you did really well there is you started to say jaundice and you focused on indirect and direct and started to say which conditions do I know that can cause intermittent symptoms. And I think that that is all those things are very plausible. What jaundice can do, though, is it can fool you. And what do I mean by that? We've gotten so used to jaundice, as I said earlier, having tremendous localizing potential. And it tells us, hey, there's a hematologic or a hepatic issue, full stop. But that's not true. Jaundice can falsely localize you to those symptoms and distract you. Let me give you some examples that you all will see when you're interns. Cholestasis of sepsis. Cholestasis of sepsis describes a direct hyperbilirubinemia in the context of really bad infections. And what happens when somebody is septic and cholestatic is people make the assumption they must have cholangitis. But it's actually not true. What ends up happening is the patient has a distant infection and the liver gets dysfunctional, just like the kidney has ATN in the context of sepsis. That is the most important example because of its morbidity of the false localizing value of jaundice. Now, what I mean by false localizing is not that jaundice isn't real. It's just that jaundice has created the illusion that the problem is either heme or hepatic and the illusion that there's something specific in there. So infections are a great example. Another example is jaundice from heart disease. Whenever you have liver heart failure causing congestive hepatopathy causing jaundice, you're often gravitating towards the liver significantly. So much so that you're worried about the liver that you keep giving the patient albumin, 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 albumin when their problem is heart failure. I've seen that twice now. So jaundice can really be a trap because it's often so freaking good at telling you where the problem is. But sometimes you have to be ready for it to be a distractor. And one clue that it might be a distractor is when it's episodic. Because episodic jaundice can easily map onto a genetic bilirubin issue that flares when a patient has a distant problem. And the leading example of that, which is prevalent in the Middle East, is Gilbert's. It's prevalent in the Middle East because I have it. And in Arabic, at least, the term yellowing, or sfarrait, is how we say it in the Lebanese dialect, is really meant to colloquially say that I don't feel well. Literally turning yellow means I'm not feeling well. It goes to show you that people can develop Gilbert's when they have some other stressor and their liver says, oh, I'm jaundiced. So for me, given the significant non-hepatic and non-hematological fingerprint of the medical history, I am open to the jaundice being a profound clue, but equally open to it being a pesky distractor by virtue of diagnoses like Gilbert, like Krigler-Najjar, or most prominently a very, very rare but very distracting condition called recurrent intrahepatic cholestasis. That is a genetic condition that causes bilirubins through the roof that our beloved Academy member Laura presented a few years ago. So I would be very, very careful about not getting sucked into the jaundice vortex here. But I'd also be careful to make sure we don't overlook it as a profound and important clue. And so I think with this history that we have here, we can really engage in the representation of the issue that this person has an extensive endocrine history: thyroid, parathyroid, adrenal. And I'm curious, whenever you have the problem representation of many endocrine issues, what kinds of possibilities start to cross your mind?
Sure. When I'm thinking of multiple endocrine issues, like the one which the patient is currently having, I'm thinking about two things, especially given the past medical history here. I'm thinking about could there be autoimmune disease which is affecting multiple organ systems? Because one autoimmune disease, you can have multiple other autoimmune disease as well. For example, if patients have adrenal insufficiency, it's also crucial to see if they have hypothyroidism, and I think that's a similar process which is at play here. This patient has at least hypoparathyroidism, hypothyroidism, and adrenal insufficiency. I think so. Three of the different organs are involved. So I think there is some sort of autoimmune attack here. So that's the autoimmune hypothesis would be number one, and also maybe a disseminated infection, which can affect multiple endocrine organs at once. For example, TB can also do that, and all of the infiltrated disorders like histoplasmosis and things like that.
Excellent. Yeah, that's superb. I'd say that that's absolutely accurate. And I will emphasize just the rarity of hypoparathyroidism. So in many patients who have many endocrine issues, you often get no specific diagnosis, but the presence of hypoparathyroidism is very, very rare. And I think that really prompts us to wonder if the patient has a specific condition impairing the parathyroid gland. So the probability of a specific diagnosis skyrockets when you have hypoparathyroidism. It's unusual for that to be part of a non-specific autoimmunity. But we're already halfway through our time, so I will share the screen to show you all the sequence of symptoms, and so you all can see it. And Kashar, please feel free to narrate it or to outline.
So yeah, the symptoms started at 8 years old with the things that we discussed before. Then the patient started having episodes of refractory hypercalcemia with symptoms that were related to that, such as laryngeal spasms, seizures, and other things that you can see on the chart. Then, as the disease developed and the patient grew, other symptoms started to show. At 14 years old, we saw candidiasis present itself. And at 16 years old, we saw kidney stones, which led to the diagnosis of hypoparathyroidism and hypothyroidism. Then at 22 years old, we saw the presentation of diabetes, then adrenal insufficiency. And finally, we arrive at here when the patient is with us for further treatment.
I can't tell you how grateful I am for you sharing this case. I don't think we've had a case even remotely similar to where I believe this is heading, and so I'm really, really excited. It reminds me a little bit of a case that Abir presented a few weeks ago, almost a month ago now, but I may be wrong. Uh, why don't you tell us? Actually, let me just ask you for time management purposes. Do you know how many aliquots you have left until the final?
I think I should combine two at here and go straight
Okay,
to the exams, because there
let's
is
do it.
no
Yeah,
go
let's,
straight to the exams and then the labs. I think
let's do it.
3 or 4
Okay,
aliquots.
let's do it.
So the drugs that the patient is taking is calcium carbonate, calcitriol, fludrocortisone, prednisolone, insulin, and levothyroxine. I have to mention that the patient is very poor compliant with their medication. There is no prominent family history or social behavior, no smoking, no alcohol. The patient has spent most of his life in hospitals. And there are no allergies that the patient mentions to us. So I think I should go here directly to the physical exam because for time. The patient was febrile with the heart rate of 80 and the blood pressure of 90 to 60 with a respiratory rate of 22 with a BMI of 15.5. I have to mention that although the pressure is low, the patient consistently had this blood pressure through their stay with us, and they were fairly stable. The physical examination didn't have much to offer, honestly, except let me double check here. Except polyuria, polydipsia, and a difference in testes size. The right testes were 15 to 20 cc's, as opposed to the left one with 12 to 15 cc's. They had dysphagia with solid foods and no abdominal pain. They had hyperpigmentation in buccal mucosa. They had no goiter, and their neural exam was normal. If you need anything else from the exam, let me know. It was otherwise normal.
I think this exam is really, really helpful. Maybe we can, because I think, as you said, there wasn't any prominent signature, at least in relation to how rich the history and the past medical history is. Why don't we get the next round of data so we have time at the end to reflect a little bit?
So, okay, I can give you the basic labs. The white BC was 1.6, hemoglobin of 8.6, and platelets were normal. Sodium of 131, potassium of 2.7, bicarbonate of 16, creatinine of 1.9. Glucose was normal, but the patient had multiple episodes of hypoglycemia, both outside of the hospital and during their stay with us. Their calcium was 4, magnesium 1, albumin 2.5, and okay, I can give 2 more. pH of 1.24, 7.24, and PCO2 of 42.
Terrific. Thank you so much. Shreya, so I just summarized, I think the two things maybe we can discuss of relevance, because this case is really all about trying to figure out what's relevant, is I think maybe getting your thoughts on what the dysphagia does for you and the hematological fingerprint of this disease, the leukopenia and anemia. What are you thinking about those things?
The dysphagia has actually completely thrown me off. I'm really not sure what to do with that. I was thinking maybe the dysphagia could be related to malignancy, given the entire presentation. But then I just want to approach dysphagia in a more systematic manner. Just ask the patient some things like, if he's having difficulty with swallowing, and I see that it's more with solid foods. So maybe this could be actually progressing, and he could also have dysphagia with liquid food. So that kinds of puts us in some sort of an obstruction territory. If he had it with solid foods and liquid foods at the same time, I would think more of a motility disorder. But apart from that, I'm really not able to tie in this dysphagia with the patient's multiple endocrine problems at this stage. And with regards to the WBC count and the hemoglobin, uh, I, I just wanted to mention one more thing about the BMI being so low and the patient having this constant failure to thrive presentation. I was also thinking maybe the whole just the whole nutrition isn't so good, that he's probably having a lot of other that is probably even affecting his immune system in a big way, and maybe the fact that uh, uh, that could also explain why the patient is having nutritional deficiency, and many of his symptoms could be explained by the fact that he's just not getting enough nutrition.
Superb, absolutely superb. Yeah, I think that it's amazing how the pre-existing context dramatically influences how we analyze this data. And to do so in a quick manner, not in a systemic manner, since yours was so excellent, I just layer on the nuances that if you're dealing with dysphagia in the context of the concern for nutritional deficiency, the most common relationship between dysphagia and nutritional deficiency is that dysphagia is causative of the nutritional deficiency, a simple association that is fairly intuitive. But is the opposite possible? Can a nutritional deficiency cause dysphagia? Thoughts from everyone, or Shreyas? How can a nutritional deficiency cause dysphagia? I'll give you 10 seconds. It involves plumbing. Plumber Vincent, exactly right. Yeah, I would think about that in this person, only because of the rich history of the nutritional risk preceding the dysphagia. And I think, as you said, the same is true of the cytopenias, and as the same is true of the jaundice. Do we use the cytopenias as a clue that there might be a hematological fingerprint, or do we just realize that this patient has had significant nutritional dysfunction and therefore is at risk of hematological disease as a consequence of nutritional deficiency? So for me, the weight of the background is so heavy that the foreground must be analyzed in that context until we get more information. So like you, I'm using the dysphagia and the hematological issues and the jaundice, and I recognize them, but I don't want to be distracted by them too much because this person has chronic mucocutaneous candidiasis and polyendocrinopathy. It's screaming to go in that direction, and these side pieces are really just decoration that might easily be consequences of those things. Is there anything else that you wanted to add, Shreyas, before we get the next aliquot?
No, not really. I'm just amazed by this case, and it's such a enriching discussion so far. I'm really eager to know get some more information and see what more this patient has.
I agree. I think Khashar has us for something really special, and I just want to acknowledge that not only is it a tremendous amount of work to put this case together and present it in a way that's enriching, the visual that you put together is just so telling of the person you are. I really, really appreciate you.
Thank you.
Yeah, for sure. All right, what do you have next?
So I can give you all more labs. The PTH was 2.6, and we had to double check the celiac hypothesis. So we got the anti-TTG IgG, and that was negative. The IgA was also negative. ACTH of 699, TSH of 2.7, T4 of 3.5, calprotectin of 0.3 micrograms per gram, and the 24-hour urine sodium was 54 milliequivalent per day.
Hmm.
I can go forward with the imaging, but I think we can stop here.
Yeah. Yeah, thank you so much. Yeah, Shreyas, what are you thinking of the endocrine dimensions of this case? What do they do for you?
I'm not really sure about the the labs, but then I think the fact that we have an anti-TTG and also the fact that the IgA was negative, it just means this patient is being compliant with the diet and the has been staying gluten-free. Otherwise, we could have seen maybe that could be the contributory factor. And the fact that his PTH is 2.6, I feel that is slightly on the lower end of the spectrum. And his ACTH is really high. So I think that there is probably I'm not really sure how to explain that. I think maybe there is a primary adrenal insufficiency and there's a response to increase the ACTH. That's so it just tells me that the pituitary is doing okay. There is no infiltration into the pituitary, and so that's
Ex-
something that's at least one bit of information which I can extract from the labs at this point of time.
Excellent, superb. Yeah, I think what has happened.
Actually,
Oh,
before we
sorry.
go on, I have to clarify something. The patient was not compliant with any of the celiac disease dietary
Yeah, yeah,
uh, things. I saw him eat bread multiple times
yeah. You know,
personally.
yeah, when you're diagnosed with something at 8 years old, you know how hard it is for all of us to change our life because when we're ill, it's very, very challenging. And then to have to do so as a human being that's not fully formed, that is still developing, is very hard. And I think the theme of our conversations in the last 2 weeks, especially with Drew's case of a patient with alcohol use disorder who succumbed to her illness at 30, it's just how hard it is when you're young to live life, even with the normal challenges of youth and teenage years, let alone with an associated medical condition. And so I think it's almost fair to expect that the patient will have significant coping issues with all these insurmountable, many almost insurmountable challenges. But to focus on the medical analysis, I think, Shreyas, what you just did is now you've taken this alleged diagnosis of hypoparathyroidism and now confirmed it. You have hypocalcemia and an inappropriately low PTH. So now you know that that ground is firm. The same is true for the adrenal insufficiency, both in the height of the ACTH, suggesting primary adrenal insufficiency, but also in this urinary salt wasting, suggesting aldosterone deficiency, causing excessive sodium in the urine, reinforcing the notion of primary adrenal insufficiency, which is, of course, further reinforced by the hyperpigmentation and the buccal mucosa and the hypotension without tachycardia, another feature of adrenal insufficiency. So you can stand on that with more. So now you know this person has primary hypoparathyroidism and a primary adrenal insufficiency. The rigorous analysis of the negative celiac antibodies is the following. The patient does not have celiac disease. The patient has celiac disease, but has not been giving the antibody the antigen, i.e. is being adherent to the gluten-free diet, is possible. And then finally, IgA deficiency would cause a false negative anti-TTG IgA, but the IgG should be positive. So here the diagnostic possibilities then go down to, is this patient does not have celiac disease or is adhering very strictly to the gluten-free diet? And with the additional piece of history and observation, we now can conclude that the patient does not have celiac disease, with one small exception. About 10% of patients with true celiac disease are seronegative in their blood, and antibodies can be stained for on the histopathology. But given the overwhelming extra GI signature of this disease that is not compatible with celiacs alone, i.e. the immunodeficiency and the polyneuropathies, I think you can say that a celiac disease diagnosis is very unlikely. So Shreyas, I think now is a good point. Actually, why don't we get the imaging, and then what we can try to do is to try to come up with a problem representation. And the challenge will be, what do you think is relevant to the problem, and what do you think is distracting you? But let's get that next round of imaging, and we can go from there.
All right. Let's go to the imaging. I'm gonna read the ultrasonography of the abdomen and pelvis first. There was a 21 millimeter stone in the gallbladder. Liver and spleen were normal size. Hepatic and portal veins were normal. Pancreas was normal. No masses were observed in the abdomen. The kidneys had reduced size of 84 millimeters and 85 millimeters, left and right respectively. Multiple echogenic subcentimeter foci were observed in both kidney, possibly kidney stones. no free fluid in the abdomen and pelvis. We also did an MR enterography and everything was normal. I can give you the endoscopy and pathology here if you like.
Yeah, let's do it.
But all right. The pathology. 2 specimens were sent, gastric mucus of the antrum, and the small intestine mucosa, both endoscopic biopsy. Histologic findings confirmed the following. From the gastric mucosa biopsy, we had mild chronic inactive gastritis, no intestinal metaplasia, dysplasia, or atrophy. GIMS staining for H. pylori was negative, and the OLGIM staging score was stage 0. Small intestine mucosa biopsy was unremarkable. Villus architecture was preserved, and no evidence of intrathelial lymphocytosis, crypt hyperplasia, or malignancy or parasitic infection were seen.
Amazing. Awesome. Shreyas, maybe for the sake of time, we can just jump to what you think is the problem here. What would you summarize as your problem representation so far?
So the problem representation so far is a 24-year-old male with chronic diarrhea ever since he was a child, presenting with wide range of multiple endocrine problems. That's the only way I could think about this. And yeah, so and also the fact that we had the biopsy, and it's overwhelming evidence that the patient does not indeed have celiac disease. We have a negative serology and also now a pathological specimen which is confirming the hypothesis. So that's where that's what I'm thinking of right now.
Excellent. Well, and of all those things, chronic diarrhea, polyendocrinopathy, um, which space do you find more enriching to guide you to the answer? What do you think?
I think the chronic diarrhea is something I would like to investigate further, but although I'm not really sure how to think about this, given that there's absolutely nothing which we can get out of the out of his pathological specimen, other than the fact that he has gastritis, which maybe even that could be an autoimmune gastritis. So that's what I'm thinking about.
An autoimmune intestinal issue is a very reasonable consideration in this patient who has multiple endocrine dysfunctions that are autoimmune in nature. Just to answer something I saw come up in chat, is just to address it briefly. What about the kidney stones? Remember that in patients with hypoparathyroidism, their calcium is low in the blood because it's being wasted into the urine. So the nephrolithiasis can be on account of the hypoparathyroidism in this patient. So that's why I'm not investing in it too much further, though I think the hypothesis of malabsorption with oxalate is certainly something that would add and worsen that problem. So, Shreyas, I think that chronic diarrhea in general, when you see this in your future career more and more so, you'll find that when chronic diarrhea is an isolated problem the patient has, then investing in the chronic diarrhea is very productive. However, when a patient has a systemic syndrome, it's very, very common for the GI tract to be the consequence of that systemic syndrome rather than the driver. And the only exception is something you said already, which is that the patient has nutritional deficiencies that are causing the systemic fingerprint. And so here, I think that my mind is very much saying, wow, to have autoimmune hypoparathyroidism and autoimmune adrenal insufficiency is exceedingly rare. And it is evocative of the autoimmune polyglandular syndromes, of which there are 3. A universal feature of the autoimmune polyglandular syndromes is the presence of adrenal insufficiency. We stratify the autoimmune polyglandular syndromes by the presence or absence of an accompanying immunodeficiency. But I should be clear before I pass the mic to you to get your thoughts on it, is whenever you have polyendocrinopathy, that doesn't mean your patient has autoimmune polyglandular syndrome. The differential diagnosis for polyendocrinopathy is best stratified as genetic or acquired. Examples of acquired polyendocrinopathy are a lesion in the pituitary that causes excessive secretion of one hormone and deficiencies of the other by mass effect. Another example are infiltrative diseases like hemochromatosis, immunotherapy-induced diseases from which we've seen very recently on VMR, and many other examples. Because of this patient's age, I think it's much more likely that the polyendocrinopathy is genetic in nature, and therefore autoimmune polyendocrinopathy syndromes become the most plausible underlying explanation. So I'm curious, Shreyas, this is a very rare space, but I'm curious what your current knowledge structure is of autoimmune polyendocrinopathy. What do you know about those conditions?
Sorry, I was on mute.
No
I think
problem.
with autoimmune polyendocrine, we had a couple of cases on VMR. So I think my knowledge is limited to what we've seen so far. I think there are like 3 different varieties of them. And then you can have multiple endocrine organs being involved at the same time. I think especially when a case where you have thyroid, which is involved along with the parathyroid gland, I think it's called the Schmidt syndrome, which was also a case on the VMR. So I think that is one variety of it. And I'm not sure of the names of the other 2 or the organs which are involved, but all that I know is there can be multiple organs involved at the same time, and each one has a separate signature of which organ is involved.
Exactly right. And I think you'll remember that you're much more likely to know the names of the other ones after this case, because I think that our dear friend is teaching us a very, very wise dimension of it. So I think that you can stratify these autoimmune polyglandular syndromes by base rate, and APS type 2 or Schmidt syndrome is by far and away the most common. And it is an autoimmune polyendocrinopathy that is the most common, but is unlikely in this case for 2 reasons. The first is the age at diagnosis. This patient was diagnosed much younger than the average middle-aged patient would be of Schmidt syndrome. And 2, more importantly, the presence of immunodeficiency. APS type 2, while the most common, lacks immunodeficiency and usually presents in adults. APSs with immunodeficiency are the things that flank it. APS2 on each side, APS1 and APS3. APS3 is otherwise known as IPEX syndrome that usually presents in infancy, very, very young. And in addition to all the polyendocrinopathies, also features an immunodeficiency and features an atopic phenotype on the spectrum of Job syndrome with EOs and IgE. There was a really nice New England Journal CPC about this, about that diagnosis. APS type 1 is a presentation that is very compatible with the current condition that we're seeing now, which is an autoimmune polyglandular syndrome featuring hypoparathyroidism and adrenal insufficiency that is also accompanied by an immunodeficiency that commonly features chronic mucocutaneous candidiasis. And so I think that would be a leading consideration in this patient. And momentum towards that diagnosis is often obtained by measuring interferon antibodies and then genetic testing specifically for the AIRE gene, AIRE. I think that the diarrhea in patients with autoimmune APS type 1 can be one of 2 things. An unrecognized infection given the malabsorptive state, but more commonly a manifestation of autoimmune enteropathy, a condition very much like Abir's condition, Good syndrome, where the idea is an immunodeficiency state can induce a autoimmune enteropathy in the GI tract. So I think as you latched on to very early on, the problem of all these autoimmune endocrine issues is the crux of this case. The filters to make progress are the presence or absence of immunodeficiency and the age of the patient. And here, the presence of the immunodeficiency and the nature of it and the age of the patient are very concerning for APS type 1. So that's probably where I would be headed, not with confidence because I've never diagnosed this condition before, but with suspicion to obtain the testing and respond accordingly. I'm curious where you're at, what questions you have about that framework, and any other thoughts that have come up since I've been speaking.
No, absolutely. I've probably just heard this condition once, and I'm very excited to see where this case is headed. I really don't have much familiarity with the autoimmune polyglandular syndrome, so I'm very eager to learn more.
Wonderful, Shreyas. Hashar, please teach us more. What did you do next, and what was the diagnosis that you all found?
Well, I love the discussion because we were literally following the same thought process and we were working up the patient for APS type 1. But before we could go with further diagnostic procedures, the patient kind of gave up on us and left the hospital, not allowing any further follow-up with him. So we couldn't follow up the patient anymore, but we were going exactly along the same thoughts. We wanted to go further with confirmation of the absence of celiac with further pathologic workup. Our first thought was APS type 1, especially since we in Iran have a population for it. It's more common in Iranian Jewish population. Interestingly enough, the patient was not Jewish. But uh, we were working up towards the same diagnosis before the patient left us.
Yeah, I think the sentiment about um, engagement with care and coping with disease as a young person or any person, I think rings true in this patient. I think that the case for it is so strong with all the data you've collected that um, I think it's a very, very reasonable empiric diagnostic strategy for the patient. And if and when he returns to care, I think that that I would I don't know how this condition is treated, to be honest with you. This goes to show how much DX bias we have as clinical problem solvers. But yeah, I think I'm glad we're on the same page. This is a very, very educational case. I'd love to hear Shreyas's reflections, what it was to discuss and reflect on this case, and then hear yours as well, Khashar. Go ahead, Shreyas.
Sure, Kasher, thank you so much for bringing this fantastic case. It was a pleasure discussing this case along with Dr. Rabi, and so much to learn. I think every aliquot just start going in a different direction and start discussing something totally new. I would never have thought that a case which started out with diarrhea would ultimately have so many different endocrine involvement, and all of this is something which I really need to read up on a lot more, especially all of the autoimmune polyglandular syndromes. And also, I didn't know how you even diagnose this case and how you can even go about with the treatment. Even that's also something which I really still need to learn about. And thank you so much for bringing this case.
I think your humility and your forward thinking is so, so cool. I thought you were very cool, calm, collected, under pressure with a with a pediatric case. Not quite a pediatric case, but a condition that is pediatric in nature and with featuring many esoteric dimensions of it. And yeah, like you, I have a lot left to learn about APS, and I'm excited to dive deeper, prompted by this case. Asher, what was it like for you to take care of this patient? What did you learn? What wisdom do you want to share with us?
Well, the treatment question, I think, is on top of everyone's mind here, and we didn't know what to do with that either. From what I've read, there is no definitive treatment for this. The main treatment course is a supportive treatment, but we were even struggling with that too. The patient was on cortisol, but as soon as we changed the cortisol to an oral one from an IV, the malabsorption wouldn't let anything get through, so the patient would experience hypoglycemia, everything would go south. It was a very challenging case, and I hope the patient is doing well, because after they left, we were all worried, like, all of these abnormalities, it's gonna haunt the patient. And it wasn't an overwhelming case, it was my literally first case as a medical student.
Wow, incredible. Well, what a case to start, and thank you so much for putting together such a complicated case and sharing the starting with us. As I alluded to, I don't think we've ever had a diagnosis like APS1. I think immunodeficiency syndromes with endocrine diseases have been only a theme recently. And so I really, really appreciate you sharing this learning with us, and really, really hope that we get to see you and your other cases here in VMR in the future.
Absolutely.
Thank you. Alrighty, Francisco, you have the not enviable job of trying to summarize the learning from this case. I'll pass the mic to you, my friend.
Hi everyone. Yeah, great case. I don't know what I liked most, if how the VMR started or how it ended. It was amazing to hear your story, Kashayar, and also great case. It's mind blowing that it was the first case that you had as a medical student. So so we started off with a patient with diarrhea, weight loss, anemia, electrolyte abnormalities, and jaundice. They were all long-standing. In terms of chronic diarrhea, we start thinking about either inflammatory, secretory, or osmotic. And when we add the anemia, we start thinking about malabsorption. And malabsorption can be caused by a GI or a biliary tract problem. So the electrolytes abnormality are understandable in the context of diarrhea, and diarrhea might be causing hypomagnesemia, and then this one cause hypocalcemia. And chronic jaundice is rare in this case. So it's a profound filter given the rarity, as we learned. And when we think about jaundice and anemia, can think of two things: is it a hepatic problem or is it an heme problem? But then we learned that it was an episodic jaundice. And episodic jaundice can be a false localizing jaundice, so it can be a distractor, which can be caused by another disease process like sepsis or heart disease. Then can be unhide a genetic disease like Gilbert that is very common in the Middle East, or recurrent intrahepatic cholestasis. And we had a very interesting teaching pearl that turning yellow in Arabic means not feeling well. I hope I'm saying that right and I didn't get it wrong. But it was very interesting. And then we learned that actually the patient had endocrinopathy, multiple, affecting the thyroid, the parathyroid, the adrenal. So we have to think, as Shreyas put out so eloquently, autoimmunity, a polyglandular disease, or an infiltrative disorder as TB, histoplasmosis, or other histiocytic disorders. And then the patient also had, we saw that brilliant timeline made by Kashayar, and we learned that the patient had dysphagia. Which could be obstruction or a motility problem. But what is interesting is that uh, what is the relationship between dysphagia and nutritional deficiencies? It is bidirectional, so the dysphagia can actually cause nutritional deficiency because the patient is not receiving as many nutrients. But what about the opposite, which is interesting? It can be caused by plumber vision syndrome, and cytopenias is actually the same. It can also be bidirectional, right? The cytopenias can be a cause and a consequence of nutritional deficiency. So that's something that we always need to keep in mind. And then we got the labs. The patient had increased CTH, which means that it's in response to a problem in the adrenal gland that is not functioning. The pituitary is, of course, not affected, so it's responding, so probably not an infiltrative disease. And this is further confirmed by the hyperpigmentation, hypotension without tachycardia, urine sodium, and the ACTH, like I said. Then we got the patient had a preliminary diagnosis of celiac disease. And the celiac antibodies were negative. So we have to think three things: are they IgA? Is it IgA deficiency? Is the patient adherent to diet, therefore the antibodies do not increase, or the patient does not have the disease at all? And we got to the conclusion that the patient did not have the disease. The nephrolithiasis is on the context of hypoparathyroidism, and and then we always go back to the center of a lot of our discussion, which is what is cause and what is the consequence, right? And chronic diarrhea in this case was probably a consequence of a systemic issue that was ongoing. Then we have to think, okay, what causes polyendocrinopathy? A genetic issue, or is it acquired? And then, as multiple are affected, we have to think about autoimmunity. And in terms of autoimmunity, in autoimmune polyglandular syndromes, we have adrenal insufficiency that's always present, and then we can make progress and differentiate the types of autoimmune polyglandular syndromes based the presence or not of immune deficiencies. The type 2 lacks immunodeficiency, and the type 1 and 3 have immunodeficiency. Here, I must make the disclosure, I'm not sure I understood it well. I have to make some learning about these polyglandular syndromes. I'm not sure about the third, but we had a final diagnosis of APS type 1 with hypoparathyroidism, adrenal insufficiency, chronic mucocutaneous candidiasis, and we have to measure the interferon antibodies gene sequence there, and I have to do some digging into the difference with IPEX. And thank you so much, everyone.
Oh, Francisco, that is absolutely amazing. You're like a sponge. I feel like you look a little tired after that, that like delivery. That's so funny.
Yeah.
Yeah, I think that you captured all that very well, and I think that I'm learning. I'm gonna steal the word bidirectional from you. That was a really cool analysis of these relationships. I'll just end by saying that the difference between IPEX is the age of onset, which is usually infancy, very, very young, in stark contrast to the APS, which is childhood. And then the atopic signature of IPEX is very unique to that condition with eosinophilia and IgE. That's probably what would help you. But we should all do more reading about it because I'm by no means as an adult doctor an expert in any of these things. But thank you all. Thank you, Parisa, for outstanding scribing, for Khashayar, for the amazing case, Shreyas, as always, for the great discussion, and Francisco for great teaching points. I hope you all have a great day, and I hope to see some of you tomorrow. Bye.